Hi, everybody. I want to welcome you to the Resident and Family Support Council meeting once again that we host on the second and the fourth Tuesday of every month at 3 o'clock. And like I always say, remember this link because we use the same link for each meeting. So the link that you used for today, you'll be able to use for any of our meetings that we have on the second and the fourth Tuesday of each month at 3 o'clock. So very excited. Today we've got a topic that I know can really, really confuse people. So that's why we brought it on board. Medicare, right? How do we navigate this system? There's a lot of ins and outs to this program, and it fulfills having this presentation today. Help fulfills the mission of these meetings. Our meeting's purpose is to empower people with information so that they can better navigate this aging path. And we do know that it can be very difficult to navigate. And I know personally, I get questions about Medicare all the time. And so today we've got Christian from the Senior Health Information Program or Portal. I can't remember what that P stands for. Sorry,
Yep.
Christian.
Senior Health Insurance Program. Yeah.
Senior Health Insurance Program. Thank you, Christian. We've got
You're
Christian joining us today, and he's going to share with us information. I'm going to go ahead. I hear somebody. I'm going to mute somebody. There we go. So if you have got questions, please do not hesitate to pop those questions into the chat. We're all about that. And Christian, if the question seems really pertinent to what we're talking about right then and there, I may just jump right in and ask that question.
And
And before we begin the basic presentation, Christian, I'd like you just to share a little bit about who you are. We love to find out who people are that are sharing information with us. So share with us a little bit about who you are.
Okay. Yeah, my name's Christian Fletcher. I have been, with the state now for going on 16, 17 years, and I've been with SHIP now for, I guess it's going on 9 years now. My background is actually in teaching. I was actually a certified teacher. Believe it or not, I taught kindergarten for a little while and preschool, but, couldn't get any other jobs. It was hard to find anything else, and so I ended up coming to the state, and I get to teach Medicare. So I'm still teaching and getting to do that. But
I
yeah,
love it. And
so
this topic
we're part
is just as important as those kindergarten topics.
Yep. Yeah, I always joke with my wife. I went from kindergarten teaching kindergartners to, teaching older people, and it's kind of similar in a lot of ways, to be honest with you.
Yeah, because we don't know what we don't know, and this can be really complicated stuff here. And I think we get a little anxiety over this topic. Many of us do, because it feels it's ever changing. As I know, you guys have to go through training every year to find out the latest and the greatest. It's really important that we all stay up to date on this stuff so we can have that empowered aging path that we need to have. So we appreciate you coming today and talking with us. Stephen is my man behind the scenes, and he just raised his hand, so he's got a question. Go for it.
yeah, Lee, I don't know if you saw it in the chat. Somebody said your voice is fairly low. Maybe move your mic closer. So I just
Okay.
wanted to make sure that you saw that.
Got it. Thank you.
That's a lot better. Actually,
Okay.
you could even talk a little quieter now. So
Okay. I better lower it a little because we know me. And
yep,
thank you for that. Whoever
no problem.
shared that with me, because I'm wearing something new today. I'm in the office and I'm trying to not impede upon other people's workspace. So, okay. Well, Christian, go ahead and why don't you dive into this topic for us and help us better understand what's going on.
All right, perfect. Yeah, and you can see my screen, correct? The presentation's on there? All right, perfect. All right, well, like I said, my name is Christian Fletcher. I am a trainer with the Senior Health Insurance Program, and kind of what we were going to do today, just kind of go over some of the basics of Medicare, just kind of refresh a lot of things. And then I did try and kind of cater this a little more towards some long-term care things in that, so we can go over that as well. But I'm going to go ahead and jump right in because I have quite a bit, there's a lot with Medicare, so I have quite a bit here to kind of go over, so we'll get started. First thing we always do is the mission of Illinois Department on Aging. You've kind of had it through the slides, kind of going through before on a lot of what the mission is. But for Department on Aging, we're here to serve and advocate for older Illinoisans and their caregivers by administering quality and culturally appropriate programs that promote partnerships and encourage independence, dignity, and quality of life. So that's what we're here for at the Department on Aging. SHIP is part of the Department on Aging, so this is kind of what we're here to do. What we are as SHIP, I kind of wanted to get that out to you as well. At SHIP, we are free Medicare counseling. We started back in 1988. We are, of course, through the Department on Aging. The key with us is we do not sell or solicit any insurance. We are completely unbiased. So when we help people, we're not going to point them towards something that we're going to get a commission on, because we do not get commissions, unlike some brokers. So that's why coming to a SHIP counselor is really important for people, because we are unbiased. We're going to give you all the information there is out there, show you all your options so you can make, the most educated decision for yourself. We are dedicated to educating people with Medicare, like I am right now. I did a speaking engagement last week in Decatur, so we go all throughout the state trying to educate people with Medicare.
And
we train volunteers.
If I can back that up about that, that you don't sell or solicit insurance, I think that is such a important thing for everybody to really hear. Because when you do reach out to other people, many times it's brokers, and they are getting a commission off of a product. So they might inadvertently kind of push you a little bit towards a product that may be a better product for them to sell, as opposed to a better product for you to be a part of. And I know I have people, friends, relatives, countrymen that are approaching that age, that magic age of 65, where we need to start applying for Medicare. And I have pointed so many people in this direction, only for them to come back and thank me tremendously for that information. So I hope everybody's truly hearing that and know that you can trust this program. They're not selling you anything. So just wanted to make sure we really drove that point home.
Very, very good. Thank you for that. Yes, that's our big main point for us. We don't sell anything. We're here to educate you so that you can make the best decision for yourself. Like I said, we train counselors all throughout the state. In fact, I'm leaving tomorrow to go down to DuQuoin and train. I think we have 30 in a class down there to train. So we have counselors all throughout the state. You email us at aging.ship@illinois.gov. And we can get you your local site and get you in touch with them. We do help enroll beneficiaries in the plans, do one-on-one counseling, things like that. All right, so let's jump right in now with Medicare. So Medicare, most of know, it's for those people 65 years of age or older. Well, it's also for people with disabilities, those that are, on collecting Social Security disability income, that SSDI. They're actually eligible for Medicare their 25th month of collecting SSDI. So those under 65 who are on disability can also be eligible for Medicare. Medicare is administered by CMS, the Centers for Medicare and Medicaid Services. Dr. Oz is over that agency right now. They're the ones who are going to make any of the laws. Any changes are done through them. To enroll and any eligibility questions is all through Social Security. So when you decide when it's your time to enroll into Medicare, you'll do that through Social Security. And it kind of makes sense, because when you retire, you're going to start collecting Social Security. So they kind of have all your information right there. And it just makes sense that they would be the ones who would enroll you in Medicare. But ultimately, it is controlled by Congress, so any changes, anything like that has to go through Congress. Once they do make changes, they let us know, and we try and get it out to everybody within our network. The key to this, we find a lot of people think once they turn 65, hey, I'm on Medicare. That's great. I got nothing else to worry about. Well, that's not exactly right. Medicare was never intended to pay 100% of those medical bills. It's there to form the foundation for beneficiaries, protection against major medical costs. So it was never going to be a 100%, where it's going to cover 100% of things. It's just there to be that foundation. And a lot of people turning 65 kind of come in thinking, well, there's going to be no cost to it. I'm covered 100%. And we need to really educate those individuals to make sure that they know, Medicare does not cover everything.
That's so true, Christian. That's really so true because I there is a little bit of people, just that belief system that, well, and then I can retire because I'm not going to need anything else. My world will be taken care of,
Yep.
and I'll have my Social Security and I'll have my insurance paid for, and it doesn't necessarily work all that way. So
yeah, it doesn't quite work that way, unfortunately.
Yeah.
We wish it did, but
Right.
yeah. So we'll go into the parts of Medicare, because there is 4 parts to Medicare. Original Medicare, when Medicare originally started, we just had Parts A and Part B. Part A is your hospital insurance, and I'll kind of go into these in a little more detail through the next slides. But Part A is your hospital insurance. Kind of think of it as inpatient care. It's more of your inpatient kind of coverage. And then Part B is the medical coverage. So think of it as your doctor coverage, x-rays, any of those extras like that. So that's original Medicare. That's how it started. Well, guess what? They realized, people take prescription drugs and they might need some help paying for those. So then they came out with Part D, which is for prescription drug coverage, the easiest one to remember, D for drug.
Hey, Will. You okay in here?
And then there's also Medicare Advantage plans. And basically what Medicare Advantage plans are, it takes Parts A, Parts B, Parts D, and puts them all into one plan. So I'll kind of go through these as we go through this. We like to use these puzzle pieces just to kind of show you how different pieces of Medicare fit together. So as we'll go, you'll kind of see more of these puzzle pieces. So I'll kind of start with who's eligible. And I said earlier, if you're 65 years or older, eligible. If you are on Social Security disability, you become eligible after 24 months. So that 25th month is when you become eligible for Medicare. If you are diagnosed with end-stage renal disease or ALS, which is amyotrophic lateral sclerosis, if I can remember correctly, Lou Gehrig's disease, they're kind of fast-tracked into Medicare. So once they're approved for their SSDI, in other words, once they're approved and say, yes, you do have end-stage renal disease or you're diagnosed with ALS, then they automatically become eligible for Medicare. Aside from those qualifications, you have to be a U.S. citizen or a legal resident with 5 years continuous residence at the time of application. So those are your permanent resident cards. I think they used to call them green cards back in the day. Those individuals that are here legally, but they have been here at least 5 continuous years before they would become eligible for Medicare. Now, there's only certain times that you can enroll in Medicare. So, think of our state insurance here. We get our one time a year, kind of our open enrollment when we can change plans. Medicare is similar to that. There's only certain times you can enroll and switch plans. First one I'll talk about is the initial enrollment period. And this is the period that is probably easiest to remember. We call it the 3-1-3 rule. It's the 3 months before your 65th birthday or that 25th month of disability, that month of your birthday, and then the 3 months after. So it's a 7-month period when you can initially enroll into Medicare. If you enroll within those first 3 months, Medicare is going to take effect the first day of your birthday month or the first day of that 25th month of disability. If you enroll, your birthday month or any of the 3 months afterwards, there's just going to be a 1-month delay for it to take effect. But that's the initial time when you can enroll. Now, if somebody is already collecting Social Security, so maybe they started taking it early at age 62, they're already on Social Security's radar, and Social Security will automatically enroll them into Medicare once they turn 65. So those that are already collecting Social Security are going to be automatically enrolled through their initial enrollment period. But anybody that is not currently collecting Social Security would have to fall within this initial enrollment period to sign up for Medicare. A lot of people are still working, especially now. A lot of us still work, past the age of 65. Honestly, I just talked to my mother last night. She's 76, and she's still working. And if you are still working, a lot of employers offer employer group health coverage. Well, that kind of somewhat duplicates Medicare coverage. And there is certain times, if you're working, you can keep your employer group health coverage and defer that Medicare coverage until you leave your employment. The key is the number of employees. If you're still working past the age of 65 and your employer has 20 or more employees, they say generally you can defer your Part B, which means you're going to be able to save that Part B premium that you would normally have to pay because you're getting your insurance through your employer. If that employer has less than 20 employees, then Medicare would be primary because it's a smaller employer group health plan, so they would still need to take Medicare. If the person is disabled, they jump that number up to 100 employees just because of the risk involved for that employer with somebody that's disabled that might have more, more bills, things like that. So they up that limit to 100 employees. The key with this is you really need to talk to your human resources, benefits manager at your employer to make sure that that employer group health plan is going to be creditable for Medicare. Like I said, generally they tell us if the employer has more than 20 employees, it's going to be creditable. But what we have found is there's some employers that might only have 10 people that they employ, but they're in a, kind of a coalition of insurance with a bunch of different companies that actually makes their insurance creditable for Medicare. So in that instance, you say, well, I only have 10 people working where I work at, I should get Medicare. Well, still talk to that benefits manager because it's possible, the way they do their insurance, you could still be able to defer that. So it's very important. We always tell people, okay, if you're in a larger employer, you can probably defer your Part B. However, talk to your benefits manager to make certain that it's going to be, creditable for Medicare. And the main reason for doing that is because if your benefits manager tells you incorrectly, well, that allows you a special enrollment period where you can then get in without any penalty. So it's always good to kind of check and make sure from that benefits manager that you can defer Part B. But if somebody does defer Part B, they will get a special enrollment period once they do leave their employer or that employer group health plan ends. Illinois Department of Insurance doesn't really have any regulatory authority over the self-insured employer group health plans. So when somebody becomes Medicare eligible, they're going to have a choice. They can reject that employer group health plan and go on to Medicare and just, be on Medicare. That's fine. Or, like I said, if they have, more, it's a larger employer group health plan, they have over 20, they can defer that. If they do defer it and it is creditable, they're going to get a special enrollment period once that ends so they can get into Medicare and won't be hit with any late enrollment penalties. That special enrollment period, they give them 8 months after they leave employment to sign up for Medicare Parts A and B. Well, the only catch with that is they only give you 2 months to sign up for an Advantage plan or a Part D plan. So you really, even though they give you 8 months to sign up for Part A and B after leaving employment, it's usually best to try and do it as early as possible to make sure you still are able to pick up a Part D plan or an Advantage plan if you would like, because you only have 2 months for that. So it's kind of a weird catch-22 little situation there. But we generally tell people, when you're going to retire, let's start things, even before you retire to make sure everything goes through, with no hiccups. We talked about Part A. Most times we find out Part A is free for most people because if you've worked 40 quarters, which is basically 10 years of employment, you've paid into FICA, which is the Social Security Trust Fund, then you have your 40 quarters and Part A is free. If you don't have 40 quarters, that doesn't mean you can't get Medicare. You're still eligible for Medicare if you meet the requirements of being 65 and, the other requirements I talked about earlier. It's just you might have to pay a premium for Part A. So we don't see that a ton, but you may see some people. The big one used to be teachers never paid into Social Security, so they would maybe have to pay for Part A, or people that, have never worked might have to. If you miss that initial enrollment period, there are some special enrollment periods that you could possibly use to get into Medicare. The first one that I have highlighted, we just talked about with active employer health insurance coverage. You'll get that 8 months after employer coverage ends to get in. If you are impacted by an emergency or disaster, we had all those wildfires in California. We've had flooding down south, a lot of these things. If that emergency or disaster affected you to where you could not sign up for Medicare when you should have, maybe you had to come up north to a family member's house and you weren't able to sign up. Well, they've now given a special enrollment period for that, so you can sign up then. If, and you see this other special enrollment right underneath it, if that health plan or your employer gives you incorrect information, they tell you, yes, it's going to be creditable, you can defer Part B, and then come to find out that's incorrect, well, they'll give you a special enrollment period for that as well. Formerly incarcerated individuals, when somebody's incarcerated, they're actually covered under the jail system's insurance. And when they were released, they used to have to wait until the general enrollment period, which we'll go over next, which is January 1st, and they would have to wait, and they would go a while without having health coverage. Well, now, once they are released, they're given a special enrollment period where they can sign up for Medicare. Coordination with termination of Medicaid coverage, this actually came out of COVID times when people were, just kind of being kept on Medicaid through COVID. Well, once that terminated, COVID ended and they were terminating people because they were actually over income, they hadn't been checking. Well, they needed to get on Medicare. Well, they've given it now, once Medicaid's terminated, they're going to be able to use that as a special enrollment period to get onto Medicare. And then there's other exceptional circumstances. Basically, what we tell our counselors is, if you think it is a really good reason and you can plead that case to Social Security of why this individual you think needs a special enrollment period, give it a shot. Because, there's other things that happen that, might work. Social Security might take it and be able to give a special enrollment period to get somebody in. So, if there's a good reason why you think this person missed their enrollment period and you can plead that case, give it a shot. It's very possible they might, use that as an exceptional circumstance and give a special enrollment period for that. The other one, and this is for these initial enrollment period, special enrollment period, and this general enrollment period, is for original Medicare, so Parts A and B. So the general enrollment period, let's say you missed your initial enrollment period for some reason. There's no other special enrollment periods that you fall under where you can get in, that way. Then you'll have to wait for the general enrollment period. And it lasts from January 1st to March 31st of each year. And you can sign up for a Medicare Parts A and B at that time. And you'll also have the ability at that time to sign up for either a Part D plan or a Medicare Advantage plan, if you sign up during that time. Generally, the month you sign up, it's going to become effective the very next month, the first of the next month. So this is kind of, if you miss your initial enrollment period, you have no special enrollment periods, then you have the general enrollment period when you can sign up. The only catch with the general enrollment period, if you've gone past a year without signing up when you should have, you could get a late enrollment penalty. So just, be aware of that. That's why we try and get people sign up during that initial enrollment period or with a special enrollment period if you can, because if you wait for the general enrollment period, you might get a late enrollment penalty.
What does that penalty look like, Christian?
Well, for Part B, it's a 10% increase of the Part B premium, and it is a lifetime penalty. So this year, the Part B premium is $202.90. So you have to actually pass a full 12-month period to hit the penalty. So if you don't make it, past 12 months, you wouldn't get a penalty. Once you pass that 12 months, then it's a 10% increase of that Part B premium. And that Part B premium increases every year, so that 10% is going to increase every year, and it's a lifetime penalty, so that penalty will not go away, unfortunately.
Okay.
Well, it's very important to sign up when you can.
Mm-hmm.
All right. There is a few other enrollment periods for Part D and your Medicare Advantage plans. They still have, during the initial enrollment period, you can sign up for Parts A and B and Part D or an Advantage plan during that initial enrollment period, because that's the time when you can get all your coverages first. The big one for Part D plans and Advantage plans is the annual open enrollment period. That's when you start seeing all the commercials on TV, talking about, it's usually Advantage plan commercials, and Part D plans talking about open enrollment. It's October 15th to December 7th. That's when anybody can change their Medicare Part D plan or their Advantage plan. If they make a change during that period, it's going to take effect January 1st. The annual open enrollment period is very important because every individual that's on Medicare has a Medicare plan is going to get what they call an annual notice of change every year. It's going to talk of any changes to their plan for the upcoming year. we try and tell all our people, look at those annual notices of change. You know, make sure you know what changes are coming up. If you're not sure, bring it into one of us ship counselors so we can go over it with you. In previous years, it wasn't we didn't notice as many changes, but here in the last couple of years, 2 years ago, we had a Part D plan that had a $9 premium. People loved it. They got into it. Last year, that premium jumped to $40. If they did not check their annual notice of change, they thought, well, everything's fine with me. Well, once January 1st came, that premium jumped up. They were screaming through the roof, why is my premium going up? Well, you didn't check your annual notice of change, and they told you it was going up, and you could have made those changes. That plan eventually this year jumped up to a $90 premium. So it's very important that people check their annual notice of change so they know what to expect in the coming year with their plan, and if they need to change to a different plan that might be better for them. But during open enrollment time, you can pretty much do anything. You can switch from original Medicare, so you might have original Medicare A and B with a Part D plan. You can pick up a Medicare Advantage plan. If you have a Medicare Advantage plan, you can switch to a different Medicare Advantage plan. If you already have a Part D plan, you can switch to another Part D plan. So open enrollment time is kind of the main time when you can really make all of your changes. And we strongly suggest everyone to, you know, come see us at SHIP. We can make sure there's Plan Finder on Medicare.gov. We can go over everything and see what is the, you know, what your options are and what the cheapest ones are for you.
So, Christian, we would go into your, we can make an appointment and go into an office to talk with you all?
Yes.
Great.
You betcha.
Okay. Great.
Yep. Yeah, and we've got offices all over the state. And to be honest, a lot of them we have SHIP counselors within senior centers throughout the state, you know. So yeah, we have counselors just about everywhere for you.
Great. Okay. Thank you.
Yeah. These Part D plans and Advantage plans also have a few extra special enrollment periods. Of course, the same one, if you retired or you had employer coverage, you know, you'd get a special enrollment period to change your Part D or Advantage plan. But if you move, Part D plans and Advantage plans are zip code specific. So if you move out of that zip code, then you're going to get a special enrollment period to get into a plan that's covered under that zip code. The one we see here a lot is those people that become Medicaid eligible or extra help eligible. And extra help, and I'll talk about that when we get to Part D, but it's extra help for your Part D prescription drug coverage. If you become eligible for Medicaid or extra help, well, then you get a special enrollment period to sign up for a plan that works, you know, for you with Medicaid or with extra help. And then the other one is there's a 5-star plan special enrollment period. So if there is a 5-star plan in Illinois in your zip code, you could switch into that 5-star plan utilizing this special enrollment period. The catch is we do not have any 5-star plans in Illinois right now. So we always check every year when the plans come out. We'll check again this year, and hopefully maybe we'll have a 5-star plan this year. The last one is this Medicare Advantage open enrollment period. And if you see the dates there, January 1st to March 31st, it's the same time as the general enrollment period, so it can get a little confusing. But what this Medicare Advantage open enrollment period, and it's only been around for a few years now, but what it is, if you are in a Medicare Advantage plan as of January 1st, then you could switch that Advantage plan to a different Advantage plan using this open enrollment period, or you could switch back to original Medicare by picking up a Part D plan. The reason why this one came into effect, this enrollment period, was because a lot of people were getting calls at home. You know, there's a lot of those commercials out there. People were getting put into Advantage plans that shouldn't have, that really wouldn't work for them, didn't work for them. And they made this Medicare Advantage open enrollment period to kind of help those people get out of those plans and get into plans that do work for them. So it's kind of a savior for those that during open enrollment that somehow get kind of, for lack of a better word, I guess they get kind of, they get talked into getting into a plan maybe that's not necessarily for them from possibly a broker that's, you know, looking for commissions. All right, so that's kind of eligibility, how the enrollment date. So now let's kind of get into what is Medicare? What is Part A? And I talked, Part A is your hospital insurance. So this is the first piece of our puzzle. And again, we're still talking original Medicare. Parts A and B is your original Medicare. So Part A, so what does Part A cover? Well, inpatient hospital care. They will cover skilled nursing facility care after a 3-night inpatient stay. Home health care, they'll cover home health care as well after a 3-night inpatient stay, and they cover hospice care. Basically, when I'm teaching our new counselors, the way I think of Part A is, if it has to do with inpatient, probably going to be Part A, because Part A is tied to that inpatient hospital stay and anything that might come out of an inpatient hospital stay. So that's basically what Part A covers. As for skilled nursing facility care, Part A is going to pay for part of those costs for a stay in a skilled nursing facility if all of these conditions are met. The main one is that 3 consecutive days or longer as an inpatient in the hospital. We usually say 3 midnights is a good rule of thumb because I believe they don't count the day of discharge as a day. What we see a lot is people go into the hospital, they're in the hospital, in a room, in a bed, but they're not in as inpatient. A lot of times they'll come in and they'll still be as an outpatient because they haven't figured out what their diagnosis is yet, exactly. And if the doctor puts in an incorrect diagnosis, then Medicare is not going to pay, for that. So they want to make sure they're getting the correct diagnosis. So sometimes people are going as an outpatient. That does kind of mess with going into a skilled nursing facility if they need to, because they have to be there 3 midnights. So that's when sometimes we'll have to work with that hospital or that doctor to see if we can get them to switch them to an inpatient, or possibly work through Medicare to see if we can get it taken care of so they can get that skilled nursing care that they need. They have to be admitted to that skilled nursing facility within 30 days after leaving the hospital, and it has to be for that hospital-treated condition that they were in the hospital for. They have to require skilled daily care per this physician order. So the doctor has to prescribe them going to the nursing facility. It can't just be for long-term or custodial care. We'll talk as I get into a little more about long-term care, but Medicare basically pays nothing for long-term care. They consider custodial care. They pay nothing for custodial care. So it does have to be skilled care for them to pay for it. And then it has to be a Medicare participating, Medicare certified skilled nursing facility for them to pay. Home health care under Part A is kind of similar. The thing with home health care that makes it a little bit easier is if they're there for 3 days inpatient, it goes, Part A pays for it, for that home health care, if it's, medically necessary and the doctor's prescribed it. But let's say they were in the hospital and they were outpatient for a few of those days, so they don't have 3 days inpatient. Well, they can still get the home health care. It's just Part B is going to pay for it then, because it came out of being an outpatient. So that's the good thing. If it's medically necessary home health care coverages, the doctor prescribes it, whether they were inpatient or outpatient, they're still going to be able to get that home health care. It's going to be either covered by Part A if it followed the inpatient stay, or Part B will cover it if it was outpatient stay. The best thing about home health care, beneficiaries are going to have to pay no co-payments or deductibles for home health services that are paid under Parts A and B. So that's a good thing. All right, so that's kind of quick through Part A. Part B is our next puzzle piece. We have Part A for inpatient. Guess what Part B is for? Well, it's more for your outpatient, your doctor services. So those physician services received as inpatient or outpatient. Doctor services are always a Part B covered service, whether you're seeing a doctor as an inpatient in the hospital or not. The doctor is always going to be paid out of Part B. Your ER services, again, ER is an outpatient service, right? So ER services make sense that Part B is going to pay for it. Your ambulance services are paid through Part B. Preventive services, those are things that, it's your colonostomies, anything that they do, your mammograms, things like that. Those preventive services, a lot of them are free. They do those for free. Those are covered under Part B. Medical equipment and supplies are covered under Part B. Like I said, your home health care, if it's not covered under Part A, it's going to be covered under Part B. And then any of your lab fees, your x-rays, your tests, things that like come out of your doctor's visit are all covered under Part B. Thing with Part B, it's only going to pay for those services deemed to be reasonable and necessary. So they're going to usually ask for a doctor's, they want the doctor to say, yes, they need this, they need this particular service, or they need this, and this is why they need it. So it just has to be reasonable and necessary for them to pay for those services.
And Christian, just to clarify, it would be like insurance where they would, you're getting into that now. Go ahead, never mind.
Yeah, sorry. So Part B does have cost to it. There is an annual deductible. That is $283 this year. It goes up every year. I believe last year it was $265, I think, if I remember correctly. And then Part B is going to pay for 80%. Well, there's still 20% left over. Medicare pays 80%. Generally, the individual is going to be have to pay for that 20% that's left over if they don't have any other supplemental coverage to help pay for that, which we'll get into a little more as well. And there is a monthly premium for Part B. That goes up quite a bit. $202.90 this year. It was $185 last year. It was, I think, $165 the year before that. So that, again, goes up every year. And like I alluded to earlier, if you have a late penalty, they're going to take that 10% off of what the premium is for that year. So that late penalty is also going to go up every year as the premiums go up. Generally, it's a co-insurance. It's an 80-20 split with Medicare. Generally, they're going to pay 80%. The individual is going to have to pay that 20% left over. There are certain things that Medicare Part B pays. It's a fixed dollar amount a person will have to pay for. Generally, the main thing we use an example is you broke a leg, you have a cast on your leg, you go in to get that cast taken off. Rather than pay 20%, they might charge you a $25 kind of co-payment for that. So there's certain things that they might charge a set amount for, but generally it's going to be an 80-20 split. So we get this a lot with people saying, you know what, that $202.90 is an awful lot. I'm going to have a hard time affording that. Is there anything out there that can help? Well, Medicare Savings Program is a great program out there. It's probably the best kept secret in Medicare, unfortunately. In fact, one of my coworkers started working in 2020. Her parents had been on Medicare for, 5 or 6 years, never been on Medicare Savings Program, and had their income was within the guidelines. They should have been getting the Medicare Savings Program all along, and they didn't know anything about it. Nobody had told them about it. So this is a huge thing that really helps save a lot of money. It is a Medicaid program, but it is not the same as Medicaid Medical. It's kind of a separate program through Medicaid that helps pay for those premiums for Medicare Part B. And depending on the level of Medicare Savings Program, it could pay deductibles and co-insurance as well. This is the chart of eligibility for the Medicare Savings Program. The first one on the chart there, the qualified Medicare beneficiary, those are our lowest income. They're that 100% federal poverty level. They probably are full Medicaid, full Medicaid, full Medicare. They have the lower resources, lower income. They, in the QMB, they would actually get their premiums paid for and any deductibles or co-insurance. So basically, they're going to end up having to pay nothing when they go to the doctor. So it's great for those individuals with the lower income that don't have the money to pay for this. Then if your income's a little higher, you can still be eligible. It's the specified low-income Medicare beneficiary. That's what we call it SLMB, because there's a lot of these acronyms there. Income's a little higher for that, up to 120% federal poverty level. Same resource limits. The only difference between the SLMB and this QMB is the SLMB's just going to pay for those Medicare Part B premiums. But as we saw, that's still saving the person $202.90 per month. So it still helps them a lot. This last one, the qualified individual one, is up to 135% federal poverty level, and it also will pay for the Part B premiums. When I first started, my question was, well, that makes no sense. Why don't they just have one you know, from 135% to 100%. Why is there the Slim B and the QI1? Well, QI1 is for those individuals who are Medicare only. They have no Medicaid tied to them. What we found is those people who are getting in-home services, say through one of the waiver service programs, and they fall into this QI1 level of income, and they are receiving those services, and those services are going to meet their spend down continuously. So they are technically continuously on Medicaid, because through that spend down, they have to make a choice. They can either take the QI1 program that's going to pay their Part B premiums, or keep the at-home services. Generally, we're going to tell them, you know, it's more important for you to make sure you can stay home and get what you need, so keep those at-home services if you can. But that's kind of the catch with that, and that's something we didn't actually know until last year, I think it was, when we had always wondered why there was two different ones, and that's when we found out about that. Somebody that qualifies as a qualified individual one cannot be on Medicaid of any type. So that's kind of the difference of why there's two separate, you know, incomes there. Telehealth's another part that's paid through Part B. It actually was they really picked up telehealth during COVID. A lot of people were using telehealth because we couldn't get out to the doctors. We couldn't, you know, go to the doctor's office a lot. So telehealth became really popular. Well, that was going to be something that at some point was going to kind of end. At first, it was going to end at the end of 2025. Then they pushed it to 2026. Well, now they actually have it through 2027. They can do now office visits for psychotherapy, any consultations. A lot of the things we hear them, they do, depression screenings has been one I've heard a lot of people do over telehealth, you know, that way. Advanced care planning, cardiac rehab services. So these are the kind of the programs that they'll let them use for telehealth. There's a lot of different things that they can do through telehealth without having to go into a doctor's office. You know, a lot of people, it's hard for them to get out, to even get to a doctor's office, or to get transportation to a doctor's office. So it's a good thing, I think, that they have, you know, extended this through at least December of 2027. So we basically got another year and a half where telehealth's going to be covered pretty fully by Medicare. So, and we're, you know, lobbying the politicians to hopefully keep this in for longer as well, because it's a big help to our beneficiaries. All right, so we've talked about Medicare Parts A and B, which I said was your original Medicare, right? It pays for your hospital, it pays for your doctors. Well, guess what? People take medications, and they need help paying for those medications as well. So they came out with Part D. So that's kind of our third piece to the puzzle there. So Part D, it's your prescription drug insurance. It's offered through private insurance companies that are approved by Medicare. All right, it went into effect in 2006. So think about that. Before 2006, people on Medicare did not have drug coverage. Well, people took drugs, right? So why was that? Well, just me personally, and just from what I've seen, if you think about how many more drugs there are out there now than there was even in 2006, right? They used to, you know, besides generic like blood pressure drugs, things like that, I think Part B a lot of times covered some of those. Well, once we start getting more and more prescriptions, it was too much on Part B to pay for that, so they came out with Part D to help pay for those prescription costs. It doesn't include doctor samples, discount cards, so you might know of GoodRx. You can, you know, there's discount cards for prescriptions, things like that. That is not included in the Part D plan. The decision about a prescription drug coverage really depends on what medicines they take. You know, what kind of coverage do you want? You know, what kind of coverage do you currently have? This is where during open enrollment time, we'll have beneficiaries come to us. We can run searches on Medicare.gov through the plan finder where we actually enter in their prescription drugs, and it'll show us what plans are out there that cover those prescriptions and what those costs will be. So that's one of our main things at open enrollment we help people with. There's two ways you can get your Part D drug coverage. The first one is pretty obvious. It's your standalone Medicare Part D drug coverage. So you have your Parts A and B. You pick up a Part D plan to kind of go along with that. Part D just covers your drugs. Or you can get the Advantage plan. Advantage plan, most of them offer health and drug coverage. So an Advantage plan basically is taking that Part A, that Part B, that Part D, putting them all together into one plan. To be eligible for Part D, you have to be eligible for Part A, or be enrolled in Part B, or have both Parts A and B. And like I alluded to earlier, you have to live in that plan service area. It's all done by zip code. So when we get into the plan finder to search plans for people, we'll get their zip code to make sure we can find the plans that work for them in their zip code that they can get. What's covered under Part D? Well, they cover brand name drugs. They cover generics that are available only by prescription. Anything that's approved by the FDA. So even though cannabis is legal in the state of Illinois, and it is not covered by a Part D plan. So unfortunately, if your doctor prescribes, cannabis for whatever, usually a lot of times it's those people that have cancer going through chemo. Sometimes they'll, prescribe cannabis to help them with the side effects. Unfortunately, Medicare will not be able to pay for that because it's federally not legal. It has to be a drug that is used and sold in the United States and for that medically accepted indication. The big one is those GLP-1 drugs. Originally, they were for diabetes. Well, that was fine. They covered it for diabetes. Well, then now they were finding that people, it helps people lose weight. So doctors are prescribing it for weight loss. Problem is, when it started out, the feds weren't covering it for weight loss. They were only covering it for diabetes. It's an example. Now, it's kind of a semi-bad example because now they are starting to cover the GLP-1 drugs for weight loss. It's just starting actually next month. So that's something we'll be getting out to everybody on, how that's going to take effect. They're calling it the GLP-1 bridge. Anything that isn't covered under Part A or Part B will be covered under Part D. Generally, drugs that are covered under Part A is when you're in the hospital and they prescribe you a drug for what you're in the hospital for. Part A is going to pay for it. Part B generally covers things that aren't usually things that the doctor has to give you. A lot of the chemo drugs, things that you can't give yourself, Part B will cover those. Vaccines are generally covered under Part B, unless it's covered under Part B. And the flu and the pneumonia shot are two examples of shots that are covered under Part B, and it was because those were here before 2006. That way I believe it worked. So they are already covered under Part B. Any new vaccines are all covered under Part D, as in dog. Insulin, biological products are all covered under Part D. And anything associated with that insulin, the injection, the syringes, the needles, the alcohol swabs, the gauze. Now, if they have the pump, is it the insulin pump that actually hooks onto them? That is actually covered under Part B because it's a pump. They don't actually give the medicine to themselves is the way we were explained to it, so it's covered under Part B because it's given through the pump. The pump is covered under Part B, but then the actual insulin for that pump is covered under Part D. So it can get a little confusing, and that's what we're here for, to kind of help explain that for people that have questions on that later. We found out long-term care, when you go into a long-term care facility, well, they have their own pharmacies. The reason is they usually blister pack their prescriptions. For individuals that are in long-term care. So they usually have their certain pharmacies that they work with. If somebody's going into that nursing home or that long-term care facility and their current Part D plan doesn't work with that pharmacy that the long-term care facility has, they got a couple options. One, they can talk to their prescription drug plan that they have and see if they can work with the pharmacy to, basically be within their, to be within their group there. So you can ask your Part D plan if they would, get a contract with that long-term care pharmacy. That honestly is pretty hard to do. So usually what will happen is you'll get a special enrollment period once you go into that long-term care facility, so you can switch your plan to whatever plan it is that works with that long-term care facility. So if your plan doesn't work with that long-term care facility, you're going to get a special enrollment period to be able to pick a plan that does work with that long-term care facility. But you will have to get that plan, that is covered through that long-term care pharmacy. Part D has some coverage phases on different coverage phases on what you'll pay. First is a deductible phase. The deductible can be no more than $615 in 2026, and that deductible has gone up every year. There is plans that have no deductible. There's some plans that might have a $200 or $300 deductible, but the key is they can have no more than a $615 deductible. Once they get past that deductible phase, then it goes into an initial coverage phase. In that phase, generally the plan pays 75%, and the beneficiary is going to be paid 25% for the prescription drugs. A lot of times, to be honest with you, generics will be free with a lot of these Part D plans. So we really just kind of check that Medicare.gov to see which plans have the lower cost for our individuals. After that initial coverage phase, I don't know, some of you might remember what they all used to call the old dreaded donut hole. Well, there used to be a donut hole, and once you passed a certain amount, you got through that initial coverage phase, then you had to pay 100% for your prescription drugs until you reached this catastrophic phase. Well, through the years, they lowered that donut hole amount, kept lowering it until finally the donut hole went away, thankfully. So now there is no donut hole. You'll have, within that initial coverage phase, you're going to pay your 75%, or you plan pays 75, you'll pay 25. After you've paid $2,100 in out-of-pocket costs, goes to catastrophic coverage, you pay $0. Extra Help, great program. It's through Social Security to help beneficiaries pay their Part D prescriptions. It is for people with limited income and resources. It's up to 150% federal poverty level, which I believe is just $19.95 a month. For income. If you fall below that, you can be eligible for Extra Help. There is $0 premium plans for Extra Help. If there is a premium for the plan, it's usually there's a Extra Help benchmark amount that they'll knock the premium off of that plan by whatever that Extra Help benchmark amount was. So they'll pay a lot lower of a premium. And then the best part is they will pay no more than $12.65 for brand name drugs and $5.10 for generics. So this is a great program. If people are having problems paying for their drugs, see if they're eligible for Extra Help, because it can really help pay for those drugs. Those who are under one of those HCBS waivers, we see usually persons with disabilities or persons who are elderly, the elderly waiver. If they're within that home and community-based waiver, they are on Extra Help. They're going to pay $0 copays for all their prescription drugs. So that's a great thing for them. They're getting these waiver services. They have lower income. They're going to pay $0 for prescription drugs through the Extra Help program. All right, so we've talked now. You have A, B's, your original Medicare, didn't cover drugs, so we brought in Part D to help cover drugs. Well, Parts A and B pay 80%, and there's still 20% left over to pay. That's where these supplemental plans come in. Kind of that puzzle piece down at the bottom there. Basically, they're a standardized insurance policy that's sold by a private insurance company with coverage specifically designed to pay the major gaps in Medicare. I'm going to kind of speed up, look, I think I'm running out of time some. But these are private health insurance companies. They are licensed by the State Department of Insurance. They're all standardized. I have I believe it's a couple slides down the way, but we have a chart of all these plans, and you'll see how there's a Plan A, a Plan B, and each one of those is standardized within that. They only supplement Original Medicare. It's going to specifically help pay those cost gaps in Original Medicare. There's a few of them now that do pay for a few extras because they found Advantage plans, they were paying for extras, so supplemental plans started doing that. So there is some that will pay a little extra, maybe if you're, foreign travel, things like that, but most of them, are pretty straightforward. They're not going to coordinate benefits with any other insurance, and we usually will call them a Medigap or a Med Sup, just a little easier to say than supplement. The best time to enroll in a Medigap plan is you'll have 6 months after you become or after you enroll into Part B. You'll have 6 months. During that 6 months, they cannot underwrite you. They have to accept you into that plan. If you go past that 6 months, they could underwrite you, and they could deny you that Medicare supplemental plan. So it's important, if you're going to go the route of a Medicare supplement, you really want to get in with that first 6 months after you get Part B, because you cannot be denied during that time. Here's that chart. As you see, plans A, B, C, D, F, all the way to N. Each plan, so a plan A, these are the coverage where it says 100%, that's what's covered. Those are actually the core benefits. But any company that sells a plan A is going to have the exact same benefits. The only difference will be cost, right? Same thing. This plan G is kind of the Cadillac plan right now for individuals. It basically pays all the extra costs. The only thing it doesn't pay is that Part B deductible. But every company that has a G plan is going to have the exact same coverages, just the cost is different. So that this is one thing where cost does make a difference. You really kind of want to look for the cheapest plan you can. All right, so Advantage plans, we said, brings everything together. And that's pretty much exactly what it does. They have to cover all the services that original Medicare covers, and the plans have contracts with CMS to provide that care to their members. Basically what happens is, because there's a lot of zero premium Advantage plans. Well, how do they do that? Well, they get a capitation rate from Medicare. Medicare pays them amount each month per member to ensure that member within, all the services Medicare would cover. So Advantage plans are getting paid. Even though your premium might be zero, they're still getting a capitation rate from the government to cover your services. To be eligible, you have to have Part A and Part B. You have to have both because it covers everything. You have to continue to pay that Part B premium. Your Advantage plan premium might be $0, but you're still going to have to pay that $202.90 Part B premium. And you have to live in that service area of the plan, just like in a Part D plan. You also have to agree to provide necessary information to the plan, follow the plan's rules, and you can only have one Advantage plan at a time. And speaking of following the plan's rules, we've had individuals who went into a doctor's office, caused all kinds of ruckus and, all that, the plan dropped them because they were, they didn't follow the rules of the plan to act right when you go to the doctor, so they can drop you if you don't follow their rules. There's some basic types. I'm not going to go through all of them because we just really see the HMO. That's where you have to use the in-network providers. If you go out of network, you're going to have to pay full cost. The plan's only going to pay if you go to those in-network providers. The preferred provider organization, the PPO, is the other one we see a lot of. That's where, yes, you have a network, but you can go out of network. But when you go out of network, you're going to have to pay a little bit more. So you can go out of network, you're going to be covered, but instead of, say, a $20 copay, your out-of-network copay might be $50. So you're going to pay a little more out of network. Private fee-for-service, we don't see a whole lot because that's where you're kind of making your own network. We don't see those a whole lot. Special needs plans we do see. There is a dual special needs plans for those both fully dual eligible Medicaid, Medicare. There's also some chronic special needs plans for those with chronic conditions, and then an institutionalized special needs plan for those who are in long-term care facilities. Then to go on, this is something we want to tell everybody. Let your beneficiaries know to have somebody authorized to disclose personal information for them. Have them have somebody who can speak on their behalf, who can get information for them, who can help them. We at SHIP, thankfully, once we're certified, we get what's called a unique ID. we can call Medicare on anybody's behalf, and we can use our unique ID, and that's kind of our blanket authorization to disclose personal information. But for most individuals, you want to have a family member. You want to have somebody you trust that can also speak on your behalf to Medicare and things like that. So it's very important people know to have these authorization to disclose personal health information forms. Talk a little bit about appeals. Appeals, there's 5 levels to the appeal. Generally, we always say the first line of appeal, talk to your doctor. Sometimes they just might miscode something. They might have made an error. Talk to them first. They can probably fix it. If they can't, if it is truly something that needs to be appealed, first place to appeal is on the back of that Medicare summary notice. And it's through that Medicare summary notice, and they can appeal right there. And I think, next page shows that's first thing of appeal. If that appeal doesn't go through, then it'll tell you exactly what to do to get to the next appeal and so on. This is something if your rights, when you think you're ending too soon, so you're in the hospital, you think you're leaving too soon, they're kicking you out of hospital too soon, you can contact Comments Health. That's what we call our Beneficiary and Family-Centered Care Quality Improvement Organization. They can help to keep you in the hospital and appeal that discharge to see if you can stay there longer. They'll do it on a fast appeal process.
And do know that same thing holds true for a nursing home stay. If you're in the nursing home and they deny your therapy services, you can always appeal it as well. You're supposed to be given that notice. And if you need assistance with that, the ombudsman can also help with that. So just know that. Yes,
perfect. And then this is another one, this advanced beneficiary notice. It's basically what it is they'll give you this notice if they think Medicare might not pay for the service. Example, my mother lives in Lexington, Kentucky. She had an episode and had to be taken to the hospital. The ambulance came to get her. The nearest hospital wasn't the greatest hospital. She knew it. My stepfather knew it. Her doctors were at the hospital across town. They gave her this advanced beneficiary notice because by signing it, it gives her appeal rights. So sure enough, Medicare denied the ambulance to the further hospital, but she had appeal rights. She was able to appeal, and her doctor said no, she needed to come to this hospital because this was where I was. The appeal was approved, and she was fine. So this advanced beneficiary notice is for benefiting the individual, so it protects them against unexpected financial liability, lets them know, hey, this service might not be covered. Here's what the cost might be. Do you still want to get it? If you sign that form, you do get the service. It gives you appeal rights. I'm going to kind of stop there just real quick with long-term care. Honestly, Medicare pays nothing for long-term care. So most everything with long-term care, you're going to be thinking about Medicaid. Generally, people have to spend their income down to become Medicaid eligible. Then Medicaid will pick up, and Medicaid will pay for long-term care. For those whose spouse maybe doesn't need to go into long-term care, they can stay out in the community. Well, there is something called spousal impoverishment. What this is it allows that at-home spouse to keep more of the income so that that person the spouse going into the nursing home can be Medicaid eligible. It's a great program. Generally, with something like that, the long-term care facility can help you with that. Once you go into a long-term care facility, they can help you with that. It's kind of a complicated process, but it's really advantageous. And here's the asset levels and resource levels. And
hey, Christian. I hate to interrupt you, but it is. Could you go back to the previous slide? Or I guess I guess it was on the slide you were on. Spousal impoverishment. When you think of that, think of that as spousal impoverishment protections. Because people hear that spousal impoverishment and they think, okay, I'll have enough to live on, but I'm going to be poor. And that's really not how the program is set up. So we want to make sure that people understand that it's spousal impoverishment prevention.
Yes, thank you.
Yep.
Yes, is that we're wanting to make sure that at-home spouse, the community spouse, doesn't become impoverished. So yes, correct. Thank you for entering that in. Perfect. And then I know I've kind of run over time. I do have some contact information for you. The main one, this aging.ship@illinois.gov. One of us here is always watching that inbox. Send us any questions you have, anything you need. If you need to find the nearest ship counselor to you, email there. We can get you out contact information for your nearest SHIP site. And I think that was it for me. Sorry, I kind of went over a little bit, kind of rushed there at the end, but there's a lot to go over. So
it was amazing, such wonderful information. I will know personally, I will be pointing people to our YouTube on this one to help explain a lot of things to them. It was really, really great information to hear. Thank you so much for being a part of this. With that, I am going to end the recording, and then we'll see if we do have any questions. Sometimes people have questions post.
Okay.